inhibitors. So this is just a review. So this is what we're talking about.
The second enzyme, HIV integrase, inserts the viral DNA into the cell's DNA. The third enzyme, HIV protease, is needed at the last steps of the viral life cycle to cut the HIV polyprotein into its individual.
So remember, these are the ones I told you are the preferred third add-on. Okay, so there's two of them, dolutegravir and raltegravir, sorry. So HIV-1, HIV-2 preferred. In terms of, they're fairly well tolerated. That's another reason why they have assumed that kind of third preferential. The only problem with raltegravir is that it has a low genetic barrier to resistance. So that means for people who are at high risk for non-adherence, then that's likely. So testing can be done for resistance ahead of time, but that may be one to avoid if people are not going to take it. On the other hand, the dolutegravir has a very high resistance to change. This is the one that is thought to be put you at high risk for neural tube defects. This is kind of, it didn't come out with that warning in the beginning, so that has kind of been noted as people have used it. So you see the recommendations. They're not recommended for those who are pregnant, especially in that first trimester. Not recommended for those who are planning to become pregnant, are sexually active, and do not use an effective contraception. The last bullet is important. If they're using effective contraception and they're willing to plan a pregnancy, then this is a drug that could be considered. But it takes counseling so that they know the risks that they are taking. The protease inhibitors, there are two of those. This is that last step. I'm not going to show that. I've showed it to you twice now. So the protease inhibitors, these have been around a long time. So this is darunavir and atazanavir. Last step, so this is where they showed you where they clipped that genetic strand or DNA strand, and then they put it into the cell's DNA. So now it's going to produce HIV viruses. So this is where we learned a lot about how to do genetic engineering. These viruses already figured it out. So we do that. We take yeast cells, we take whatever we want them to make, like an insulin, stick it in their genome, and they produce insulin for us until we kill them or tell them to stop. So it's a very similar process, but they're using it to produce viruses. HIV-1, HIV-2, high genetic barrier to resistance. That's good. That's what we want. The adverse drug reactions, this is the one that I told you that I see people in clinic for diabetes. This is the class, the protease inhibitors, where patients are likely to get diabetes. So patients who are already at high risk for diabetes, and if there's an alternative that can be used, that would be a good one. But I have seen all manner of people get diabetes from the protease inhibitors. You also see lipodystrophy. So those kind of go hand in hand. And that is a common problem with HIV therapy. You also see PR interval prolongation. That, as far as I know, are about the only class that does that. Darunavir, if you look at it, it is well tolerated. Most of the adverse reactions are fairly low grade, but it does have the potential for those life-threatening hypersensitivity reactions. So patients really need to be taught about what those look like, making sure that they get into contact with the people who are taking care of their healthcare providers, or if they walk into your urgent care or your ER, you have a high awareness for that Stevens-Johnson's or TEN reaction. So atazanavir is one that is usually given with a booster. It does not cause insulin resistance, so that might be one to choose, a protease to choose, or inhibitor, if you want to use that class in somebody who has high risk for diabetes. What you see there are mostly liver and kidney side effects with this drug. So it makes it kind of tough. Some of the classes have commonality in their adverse effects, and some of the others have none. Makes them a little bit difficult. Okay, on the next page of the pharmacologic boosters, you have Protease and ritonavir. So we've talked already a little bit about them. They are used to boost the effects of another drug. Ritonavir has some, it is a protease inhibitor, but it's very weak. Cebostat has no antiviral activity. So I would consider that for both of them. There's no, you're not going to get any gas out of either one of those in terms of affecting the virus. It's helping the other drugs that you're using. Let's see. Look at the other things that I haven't told you. Mostly 3A4 pathway that they are going to impact. Let's see. Down towards the end, the Cebostat is well tolerated. So you can see serum creatinine go in, mostly not because you're affecting the kidney so much as that you're affecting the ability of it to get rid of creatinine. GI toxicity, lipid changes, there it is again. Questions about those? All right, let's look at the fusion inhibitors. So these are part of, the next three are the viral entry inhibitors. So you've got the fusion inhibitors, the Ccr5 Antagonists, and the Cd4 Post-Attachment Inhibitors. If you look on the next page, you see a picture of what those fusion inhibitors are doing. So this is showing you on the left-hand side normally what would happen when the cells fuse, release of those enzymes so it deploys its ability to replicate and to make it the virus, and then to the protease inhibitor and the integrase inhibitors. And then this is where this drug is stopping them. So let's go back. Yeah.
So are the PIs the only ones that require the pharmacologic boosters?
Yes, I think so.
Okay. Well, we haven't run across it either, so.
I don't think the MMRTs do.
Occurring after attachment and co-receptor binding, the third step in HIV cell entry, fusion, also represents a target for antiviral drug development. One model of fusion requires GP41 to undergo an extensive structural reorganization in order to destabilize the viral and cell membranes. That bind GP41 and interfere with this process have the potential to prevent HIV cell entry. Drug candidates that block GP41, known as fusion inhibitors, are currently in clinical development.
Okay. So as far as I know, this Enfuvirtide is the only one on the market, but I do believe there's others. I didn't go look at what's in the pipeline. But these are where you're going to add these to where you've got problems in a drug regimen. So if they are doing well on an NRTI and a third, that 3-drug regimen, you're going to leave alone. If their CD4 count goes up and their viral load goes to 0, you're not going to do anything. But if you're continuing to have trouble in achieving that viral load reduction, then looking at these type of viral entry inhibitors is warranted. So you're always going to use it in combination. This one is an injectable, so that might be a downside. It's given subcutaneously, it's every 12 hours, so they have to inject themselves twice a day. I think this approach is just ingenious. I think it warrants, and that we'll see a lot more of this. The next are the Ccr5. If you look on the next page, you see a picture of those. Looking at those co-receptors. You see where you've got 2 co-receptors, you've got the Ccr5 and that Cr4. So most people, the majority of people, 60% plus, have that Ccr5 co-receptor. Very few people in the United States have the Cr4. If they do, using a Ccr5 inhibitor or antagonist is not going to work. The rest of the people are dual receptors. They'll have both. And he'll talk about this in this video. So the one we're looking at right now, again, there's only one that I know of, is that Maraviroc is the name of it. I spelled it wrong in your bolded, but underneath it, it is spelled, it's Maraviroc.
HIV/AIDS,
He's a little bit prophecy
once a challenge to treat, is becoming a highly manageable chronic condition. HAART, or highly active antiretroviral therapy, is continuously evolving and improving. As a result, people living with HIV/AIDS and undergoing therapy now lead longer and improved lives. Current HAART includes oral antiretroviral agents, or ARVs, that target the virus after infection of the host CD4 T cell. These ARVs target the replication cycle of the virus, such as reverse transcriptase and assembly stages. Recent developments in HIV research target the virus before it infects the host CD4 T cell. These developments focus on the attachment, co-receptor binding, and fusion stages of the viral life cycle. An injectable fusion inhibitor targeting the later fusion stage of HIV entry is currently available. However, ongoing research targeting the earlier stages of viral entry for oral HIV therapy has gained much attention over recent years. Infection of the CD4 T cell by HIV occurs in 3 distinct sequential stages. In the first stage of the viral life cycle, known as attachment, the viral glycoprotein 120, or GP120, on the surface of the virus binds to the CD4 receptor on the surface of the host cell. Next, GP120 undergoes a conformational change, which allows it to bind to a second receptor, or co-receptor, on the host cell surface. Binding to the co-receptor is critical to the virus, as without this event, HIV cannot enter the cell. Finally, co-receptor binding induces structural changes in another viral glycoprotein, known as GP41, which result in fusion of HIV with the host cell and allows entry of the virus into the cell. The co-receptors to which HIV-1 can bind are part of the chemokine co-receptor family of proteins. The virus must bind to one of two chemokine co-receptors on the host Cd4 T cell surface in order for infection to occur. These co-receptors are Ccr5 or Cxcr4. HIV-1 is selective for the specific chemokine co-receptor to which it binds. This selectivity or affinity is known as viral tropism. Viruses that bind exclusively to Ccr5 for cell entry are known as R5 tropic viruses. Viruses that bind exclusively to Cxcr4 for cell entry are known as X4 tropic viruses. And viruses that utilize either co-receptor are known as dual tropic viruses. A patient's HIV infection can thus be categorized as R5 tropic, X4 tropic, or dual tropic. In cases where patients are infected with combinations of R5, X4, and or dual tropic virus populations, their infection is classified as mixed tropic. Dual tropic and mixed tropic HIV infections are categorized as dual mixed tropic. Analysis of tropism prevalence in recent HIV clinical trials has shown that approximately 50% to 60% of highly treatment-experienced patients are infected with R5 tropic virus. Infection with dual mixed tropic virus accounts for the majority of the remainder of infections. The prevalence of X4-only virus in this patient population is rare, occurring in up to 4% of patients. The rationale for targeting viral entry as a novel approach to HIV therapy arose from the discovery of a commonly occurring Ccr5 mutation known as Delta 32 on chromosome 3. Delta 32 homozygous individuals who have two copies of the Delta 32 mutation and therefore lack functional Ccr5 co-receptors are highly resistant to HIV-1 infection. Delta 32 heterozygous individuals carrying one functional Ccr5 gene, while still susceptible to HIV infection, display a delayed progression of the disease compared with normal individuals who have two functional copies of the gene. Importantly, it has been found that Delta 32 homozygous individuals are healthy, indicating that lack of Ccr5 expression does not appear to be deleterious. Thus, targeting Ccr5 and blocking its interaction with HIV may offer a promising new approach to combat the virus. The discovery of the Delta 32 mutation in the Ccr5 gene led to the development of a new class of drugs that target the Ccr5 co-receptor to stop HIV infection by blocking viral entry, known as Ccr5 antagonists. This new class of anti-HIV agents functions by binding to the Ccr5 co-receptor on the surface of Cd4 T cells. Binding of the co-receptor by a Ccr5 antagonist causes conformational changes in the co-receptor, rendering it unable to bind to GP120 and complete the entry process. Therefore, the virus cannot infect the Cd4 T cell and replicate. As a target, the Ccr5 co-receptor shows promise for interrupting the HIV life cycle before Cd4 T cell entry. Ongoing research into HIV entry and development of agents such as Ccr5 antagonists may help clinicians and patients to better meet the goals of therapy.
Isn't that cool? Does it remind you of science fiction? Don't you feel like science fiction writers must have known viruses and stuff? Or the people who draw them are science fiction aficionados? I thought his explanations were really good. Okay. So, and just to point out at the bottom, the life-threatening reactions are liver, heart, skin, and allergic reactions. So it's those same things we've seen over and over again with other drugs. The last of the viral entry inhibitors is the Cd4 Post-Attachment Inhibitor, which is a belazumab. Okay, so what does that name tell you? It's a monoclonal antibody. Any guess as to what kind it is? It's humanized because it's Zumab. Okay, so it's 90%. It's greater than 90%. It's not fully humanized, but it's what we call humanized. Okay. So it is used in people who have been exposed to other treatments. So they've been on HIV medicines in the past, or they have a strain that is resistant to current medicines. So you're not going to see this added to everyone early on, or if they're not well controlled. So it's always going to be used in combination. There's no drug that we wouldn't say that about. Let's see. So this one, the iris is really strongly seen with patients like this in terms of the immune system, recovery and response. And we'll go over that next. It's interesting, this drug, it doesn't really block it blocks it physically. So watch the interaction. It's different than what you see. The virus can still attach, but because this thing is so blocky, it kind of keeps it from doing, the virus from entering in a way we haven't seen yet. I don't know why I didn't do HIV, because I love the mechanisms. I think they're amazing. I just get excited to listen. I just think the people who do this are so cool. Yeah, he says the drug fund.
Ibalizumab is a humanized monoclonal antibody with a novel mechanism of action among HIV antiretrovirals. Infection of target cells by HIV is dependent on surface representation of cluster determinant 4, Cd4, which serves as a specific virus receptor. As an anti-CD4 monoclonal antibody, ibalizumab blocks the entry of HIV into CD4 positive cells. Ibalizumab binds to the D2 domain of the CD4 receptor on the surface of the T cell. The ibalizumab binding site is distinct from the D1 domain, the binding site of the HIV envelope glycoprotein GP120. The ibalizumab binding site is located on different CD4 domains and is on opposite sides of the CD4 receptor. The presence of ibalizumab does not affect the binding of GP120 to CD4. But through the mechanism of steric hindrance, ibalizumab prevents the structural shifts required by GP120 for virus entry. The so-called steric hindrance involves physical clashes between ibalizumab and the GP120 glycan molecules shielding each spike. As a result, the process of HIV entry into the host T cell does not occur. Although ibalizumab binds to the CD4 receptor with very high affinity, it does not appear to alter its normal function. The major histocompatibility complex 2 molecules bind to the D1 domain of CD4, a position similar to the binding site of the HIV envelope glycoprotein GP120. Unlike GP120, however, the major histocompatibility complex 2 molecule's binding site is spatially separate and distant from the D2 domain and is not affected by the presence of ibalizumab. Therefore, ibalizumab should not affect the normal adaptive immune response.
Even though, from what I've told you in the past, if you have different mechanisms, you can use them together. I have not seen anything that recommends that, but I will say
HIV is a retroviral.
I'm not so well-versed in the scope of treatment that I could say that. I think what probably keeps them from being used together, all these different viral entry, because it would make sense to me, you have an extremely powerful combination, is the side effects. And you're multiplying, especially that hypersensitivity reaction. Okay. Did she say anything or mention those drugs? Did you all talk about the viral entry inhibitors?
She mentioned the class.
Okay. I don't think she practices in HIV anymore. She used to, so she may not be familiar because these have not been around very long. Okay, so let's talk about the iris. I think it's really fascinating. This is a great explanation. Do y'all ever use Khan's Academy? I think they're great. This one is fairly long. It's about 10, but he really does a good job. So you might want to look at it as a review of everything. It's excellent. So what did you learn about iris or immune? It's got different ways people will use an acronym. Immune reconstitution or restoration syndrome, or immune reconstitution inflammatory syndrome. So that's where the iris part comes. What did you learn about it?
I think she briefly mentioned it. It's like where your symptoms get worse or exacerbated because your immune system starts working.
Right.
Yeah.
So think about it this way. You suppress, the viral suppression just tells you it's not making it anymore. But when that Cd4 count starts coming up, then your T helper cells are back in business, right? So if you've been infected, but your immune system could not respond to that infection, then you would have no symptoms. Okay. So what happens is you boost. Your immune system is returning. It's getting healthy again, and all of a sudden it finds out that there has been an infection hiding in you for months. Okay. So what it does is they get sick. It's like a new disease. So the example I gave you in there was they started noting that people, they use CMV as a example, but person got, immune seems to be responding to therapy, and all of a sudden this opportunistic disease pops up. So eventually people said, okay, it was always there. And so now your immune system can attack it. So you see the list there. It's very common when people are starting therapy or they are changing therapy and ramping it back up again, are the most common times. Happens in about 20% of people. So not everybody gets it, but it is 20% is significant enough that you're likely to see if you work with that population. Okay. So look at the list. It's a good thing in that the immune system is getting stronger, and we keep using the antiretrovirals, and we treat the other infection they've gotten. So look at the links. So CMV, very common, opportunistic illness that they can get. Cognitive memory and thinking problems. So it seems to be a minor cognitive disorder. I don't really know a lot about it. But it was listed as one of the problems that can develop. Cryptococcal meningitis, so fungal meningitis. Hep B and C. We talked about this with Hep C, is that you start treating and suppressing. Sometimes you get Hep B comes out. Anytime you use an immunosuppressant, we talked about those activations of those other illnesses. This is kind of the reverse. It was there, can respond to it, now we see it. Herpes zoster, so shingles, herpes simplex, the MAC that you all talked about earlier, the progressive multifocal leukoencephalopathy. Did you all talk about that in PML in neurology? Or at some point you've had it? So a viral brain infection can be really very serious. Or they can just get a lymphadenopathy, tuberculosis. So sometimes what you can do is you can use a course of prednisone, especially if inflammation is a major source of it. Now that might be counterintuitive because a lot of times with these infections we would not use a steroid. But sometimes they'll do it just to tamp down the response and so the person can recover more comfortably. So that's what iris is. Very, very interesting. Page 13. Adherence. Again, always think, you should just, when you see a person on drugs, my little face should float up and say, don't forget adherence. Assess it, assume non-adherence. Always ask them, how do you remember? How are you taking it? If they are non-adherent, get them plugged back in. to assist them. Make sure they understand that link between adherence and drug resistance. You don't take it, then they're not going to work. Patients will always over-exaggerate their adherence to you, always. I gave you a study there. It's probably halfway down. Adherence is difficult to assess. One study demonstrated that clinicians incorrectly predicted adherence in 41% of their patients. I can't believe it's even that low. Because most of the time when I'm talking to physicians, they're like, I started this drug and they went to the hospital and they crashed. So what, not that they say to me, what do they do now? But a lot of times I would get it with kinetically active drugs. Or drugs that not kinetically active, drugs that we monitor, like seizure medicines. So they come in, they tell the doctor, I'm taking this much carbamazepine, they put it on it, and guess what happens? They get toxic. It's because they didn't take it. They have increased the dose against non-adherence. Okay? And I'll tell you, providers are sucked into it all the time because patients are never going to tell you they don't take the drug. They're just not. You have to assume they don't. So that's why I look at day supply. That's why I call the pharmacy and say, when they last get this filled? You surely have run into this at Good Shepherd. So always remember that people will do it. I will do it in ways that, you can see in this class how long it takes y'all to calculate it. If I took your calculators away, you kind of glaze over. Well, that's what I do to patients. When did you last get that filled? And so usually if they'll tell me I can calculate real quickly, you should have run out 2 weeks ago. Okay? Or I know it with insulin. You got a vial of insulin a month ago and you take 100 units a day. Okay, you should have been out of that 20 days ago. I use those kinds of things. Okay? It's like when I ask somebody, how much do you drink? And they tell me, and I've got a high suspicion they drink a lot. It's like, well, how do you usually buy it? Fifth? Yeah, I buy fifth. How long does the fifth last you? They can't calculate it fast enough for me that I can figure it out. So it's not that I'm not that bright. I just figure it out over time that there are ways to start to figure out what people are doing. So always assume non-adherence. Look at what their barriers are to getting their drugs or taking their drugs or understanding. Let's see. Oh, so at the bottom, I never tell patients this, but there are drugs now are more potent. They are longer lasting. They have higher barriers to resistance. So that means that non-adherence doesn't impact it as much. And maybe in your lifetime, you'll see more and more drugs for HIV come out that do that, so that we have some buffer against non-adherence. But if patients have missed doses, then it's worth repeating that viral load and seeing where they are. So lab monitoring, y'all talk about HIV monitoring the viral loads and Cd4. Okay. So we want their viral load non-detectable. We want their Cd4 values up in the normal range. So how fast that occurs is going to depend on the drugs you're using. So look there in the middle. The most rapid decline in viral load comes with the Integris strand transfer inhibitor based regimens. So those that are taking that along with the NRTIs. Okay. The non-nucleosides, so if they have NRTIs with their NRTIs, then that's in the middle, and then the protease containing regimens are the slowest. So those could take several weeks. The expectation is that the HIV load will decline by at least 1 log, so tenfold, in 1 to 2 weeks, 2 logs in 4 weeks, and non-detectable in 8 to 24 weeks. So if you're looking at lab, you can kind of see where they are. If you know they've recently started and you see their viral load is still detectable, then you know why, because of the effects of the drug. Cd4 counts 3 months after initiating therapy, and then every 3 to 6 months. Other things you're going to be looking at: kidney, liver. Next page. Cardiovascular. So remember, some of these have EKG changes. So PR interval for one, QT interval for others. Dyslipidemia, really, really common. And what drug do we use? Statins. And what is the problem there? Drug interactions. Okay? So keep that in mind. If you have to change it, if, let's say, they come in and they tell you, my insurance will no longer pay for atorvastatin and I have to switch to simvastatin. Well, simvastatin has many more drug interactions than atorvastatin. So think about that. The class overall, big drug interactions, and in it, simvastatin is the worst of the interactors. I know you will remember all of this. Okay. Diabetes. So those protease inhibitors, very, very, very common. All right. So considerations prior to initiating treatment. Again, they're going to look at their comorbid diseases. They're going to look at, particularly if they've got, if they have a history of Hep B or Hep C, psychiatric illnesses. What's their viral load? What's their CD4 cell count? They're going to use a Bacavir. They're going to test for that allele. And we're doing that because of what? We're worried about what? Hypersensitivity reaction. The regimen itself, how complicated it is. The more complicated, the lower the adherence. So pill burden, how many pills do they have to take? Drug interactions, food or fasting requirements. Drug resistance, if you've got somebody who has been on a regimen and now they're coming back because they're not responding or they're not adherent. So those are kind of the overall big things to remember with the drugs. You ought to at least know what the drug classes are, what their main mechanisms are, how they're put together, what their role is, and big side effects. Because I think that's where it's going to hit you the most. Did you all talk about prophylaxis? Okay, so PrEP. So people who do not have HIV, but they're high risk. Let's say their partner has HIV, or they don't have HIV, but they have sex with people who have HIV. Okay? So we have protocols now to put them on a tenofovir regimen, an M-tricytidine, to try and prevent them from getting it. Okay? Greater than 90%. There are a lot of pharmacies, particularly on the West Coast, in Oregon and California, some pharmacists specialize in this in community pharmacies. So people can walk in and they require counseling. So they counsel, they screen, they counsel, and then they can initiate therapy there. So because the population is high risk, they have made it so that it's very available because pharmacies are open and more accessible than a lot of other providers' clinics. So that's one place they can get it. So who should be on it? Prevention option for sexually active men who have sex with men. Recommended as one prevention option for heterosexual adults and women who are at risk because of their practices for HIV. Next page. Recommended as one prevention option for adults who inject drugs. And then for heterosexually active women and men whose partners are known to have HIV. So keep that in mind as you screen people, as you're talking, because you're going to ask them about or they may approach you. You know, I'm late life. What's the fastest growing group of HIV in the country? It's like the over 60s. It may not be, it was last year or two, but that's one of the fastest growing groups. So people are getting married later in life to someone, second, third marriage. So that's one thing that needs to be kept in mind. All right. Aren't you glad you came today? This is a great day. Okay.